Hi, I'm Hasenin Al-khersan at the Retina Group of Florida. I'm a retina specialist practicing full-time, and I'm here at ASRS where I presented on geographic atrophy progression rates in patients before and after they were treated with Pegcetacoplan, and in patients both with and without neovascular AMD alongside their geographic atrophy. So the study that we performed was done on routine clinical data from the RCA registry, and we used Retina AI's discovery platform to analyze using artificial intelligence, the photoreceptor layer and the RPE layer. And what we found was very interesting. First of all, in terms of baseline lesion sizes, both in RPE loss and photoreceptor loss, there were equivalent baseline lesion sizes between the cohort GA-only eyes and GA with concurrent neovascular AMD. Patients were treated at similar intervals with Pegcetacoplan in the treatment phase of the study, which was about every 6 weeks. In terms of the results, so before these patients were treated with Pegcetacoplan, there were similar progression rates both for photoreceptor loss and RPE loss in the GA-only cohort and in the cohort with GA and neovascular AMD. However, once the patients were initiated on therapy and we followed them out for at least 1 year, we saw that there was a statistically significant decrease both in the photoreceptor loss and also a decrease in the RPE loss in both cohorts, that is the cohort with GA only and GA with neovascular AMD. And interestingly, there was actually a greater treatment effect in those patients with GA and neovascular AMD. So what this tells us is that the Pegcetacoplan is not only effective, but perhaps even more effective in those patients with GA and concurrent neovascular AMD. And this is important because it's really a cohort of patients that were not evaluated in the clinical trial. And so these are some of the earliest and most robust results evaluating these patients. And they're patients that we are routinely treating in the real world with Pegcetacoplan. So historically, we had a difficult time measuring geographic atrophy in patients who had neovascular AMD because that can create some confounding effects. For example, if the patient has subretinal fibrosis or SHRM on their OCT, that can affect the measurement of the geographic atrophy. Our technology has improved quite significantly, and also the way that we set up this trial with a certain amount of manual and automated quality control, we were able to neutralize some of those confounders that historically have been problematic. It's very different when a clinical trial is being established trying to reach an endpoint. There's a lot less risk that can be taken for the program versus in these real world studies where we have more flexibility, a much larger patient base that we can do these sorts of analyses. Certainly for photoreceptor characteristics, the signals that you're looking for on the OCT are so small. To do it at scale, it's just incredibly tedious. And so, moving forward for these large scale studies, in my opinion, there's really no way to do it except with the use of artificial intelligence to allow you to scale. There is, again, room for quality control that's both automated and manual. But for the actual the baseline work itself, I think it's much better served with the automated tools. And as we also expand what we're looking for, the different biomarkers we're evaluating, the more and more you kind of stack on, the more reliant I think we'll become on AI tools for this. I think the big gap is getting these tools in the hands of clinicians through FDA-approved, tools that we can deploy and use to teach our patients and learn in clinic. Right now, these are all really research exploratory tools. It's great. It generates evidence that we can use to inform our patient selection or assess, treatment response, but we don't have a way of actually assessing that in a live fashion in the clinic. And I think that's the big gap that's really remaining there. I think the fact that we saw a greater treatment effect in the cohort with GA and neovascular AMD, I was not necessarily expecting that. The question we went in with is, does this work at all in patients with those combined diseases? So learning and seeing that maybe it actually works better than even what it does in just GA alone is very interesting. I think it needs some more exploration, but Nimo Patel actually gave a talk here today where they were looking at similar cohorts comparing GA only and GA with neovascular AMD, and they actually found less vision loss. They were looking at visual acuity in their registry, less visual acuity loss in treated patients in that combined cohort. So it's really nice when you see consistent results, and we did not coordinate our studies at all. So when I heard it today, I was like, oh, that light bulb's going off. It kind of explains the two findings that we're seeing here. In terms of mechanistically why does that happen? We need to understand that better. It may be the case that in patients with combined disease, the complement process is actually, even more overactive. But we need kind of more nuanced studies to understand that better. The gap that this fills is that, in my clinic and a lot of clinics, for the docs that are using Pegcetacoplan, a lot of them are treating patients with combined disease. But before, we had essentially no data, certainly no data as robust as this to tell us, if it's working at all in our patients with those combined diseases. Now we can feel more confident saying that, not only is this working in our bread and butter GA, but in those patients that we're treating with both diseases, we can expect a treatment effect. And it allows us to have those conversations with patients armed with more knowledge. And that's important because we know there's a huge overlap in diseases. Patients with GA get neovascular AMD and vice versa. And so, I think this is a question that we needed to answer. I think there are other nuances remaining. For example, if a patient has neovascular AMD and then develops atrophy, does that behave similarly to if a patient has atrophy and then develops neovascular AMD? So some more kind of threads to be pulled on in terms of future analyses.